team lead for the surgical site infection mistake proofing project. This is our standard work combination sheet, and we'll be speaking to a tack time of 20 minutes. This is our team picture, and we are known as the CSI, or the cesarean section investigators. Jerry Cruz isn't able to be with us today. He's in the Philippines, lucky guy. Anyway, this is our project form, and the goal of our project was to reduce the incidence of post-surgical infections in all cesarean sections completed at the Victoria Hospital. So to get started, we were given the surgical site infection bundle, which included 4 components. There was antimicrobial coverage, my mouth is dry, appropriate hair removal, maintenance of peri-operative glucose control, and peri-operative normothermia. We were also given the information on the 4 types of surgeries that were being tracked by the infection control officer and their infection rates. So from that information, we decided to go with the cesarean sections, because we do more cesarean sections than any of the other surgeries in the hospital. We also looked at the surgical site bundle again, and then chose to look at the antimicrobial coverage, and more specifically the prophylactic antibiotic use, because hair removal and normothermia were already being addressed, and we just felt that the antimicrobial coverage was something that we could actually have some impact on. So as you can see from the graph here, these are the infection rates for quarterly from January 2012 to the end of June of 2013 for the cesarean sections in the region. This is our value stream map. Oops, you can go one more. This is our value stream map that we developed at the beginning of our project, and as you can see, our non-value added time is really very little for the patients, and are at 6%, and our value added time was 96%. But we did see several starbursts that came out of our observations, and our main focus was on the antibiotic administration and the timing of that. So from our assignment sheet, you can see that pre-project, 11 of the 112 cases, their prophylactic antibiotic was not given, so that was a 10% defect rate. Next slide. And post-project, we had 9 out of 131 cases that did not receive prophylactic antibiotics, so for a 7% rate. Next slide. So that equated into a 30% improvement rate from start to finish of our project.
Thanks, Nola. Good morning. I'm Johan Musen. And just to give you more background, to start our journey, we decided to understand the current situation. So we collected more information regarding C-section and infection from January to June 2013. Initially, we got information from OR manager that we have 133 C-sections that were done. But then from obstetrics and infection control, that they confirmed that we only have 128 C-sections that's been done. So from that alone, you can see we have different information from several places, and they're conflicting as well. After which, to compare the present data from January to June, we checked out charts from July 2013 to February 2014. We were able to review 112 charts for the months of January to June, and 135 charts from July to February. So we do have a margin of error of 13% for last year, and 15% of margin of error. Next slide, please. To further to get patterns, trends, risk factors, we decided to create a simple database just to know what's the commonality between all the C-sections and the infection among all the patients who have surgical site infection. Next slide, please. So, although we have 128 cases for the month of January to June 2013, we decided to go with a baseline of 112, since those were the charts that we actually put our eyes on. So we have 9 out of 112. To start with our root cause analysis, we did a fishbone diagram with the OR staff and gathered more information on why they think and how they think antibiotics were not given, and also why surgical site infection occurs. This has helped us to do focused problem solving. So we created a Pareto diagram for preventable causes of surgical site infection. As you can see, the number one is people are coming in and out of the OR during a case, during a C-section. The second one is that we have lack of data quality. The third highest one is inappropriate PPEs, although we're not gonna address, in this mistake proofing, we're not addressing to that. And then the fourth highest one is no antibiotic prophylactic administration. So this is our pre-target progress report and result sheet. We decided to measure four big factors. First is to receive antibiotics prior to C-section. We have a baseline of 90% and we want to put it to target 100%. The next one is the submission of the golden rod surgical site data collection form. We started with 46% and our target is again 100%. The third one we're measuring is the receiving of antibiotic within 60 minutes, 1 hour prior to incision. So we have a baseline of 93 and we want to target 100% as well. Last but not the least, we are measuring the number of people in and out of OR during a case, and our baseline is 46 and we want to put it to 0. So for our first PDSA, since we recognize that information is our source of, or our golden source, we wanted to address to that. So this is the idea and summary that we got from this. Next slide, please. So to help us with our to gather opportunities to mistake proofing, we decided to do a process mapping to understand the flow of the surgical the flow of the golden rod form as from how it's being placed in the OR package to how it's being submitted. So the main objective of this PDSA is to improve accuracy and help the infection control and chart in finding more information about the certain patients, and also to have 100% submission rate. Please. So this is the picture of the old data collection tool, and for the new and improved data collection tool, it's more aesthetically appealing. It's easy to find. The drops are easier to find, and we've also categorized each area which one should be answered by or filled out by OR staff and recovery staff. So we created a work standard as well, and they've been communicated to OR staff and recovery room staff. With this, as you can see, we have multiple skills. The training checklist has been completed by the two departments already. So as a result, you can see the yellow trending line there. We started from 40% baseline of non-submission of golden rod forms to a 99% now, starting from November to February this year. And we got information from infection control that it's easier and faster for her now to track surgical site infection for particular patients. Thank you.
Thank you, Johan. So our next two PDSAs look at antibiotic administration, and as noted, antibiotic administration is part of the SSI bundle, and we determining the number of antibiotics given was actually quite difficult. And initially, when we had reviewed the goldenrod forms, we had only found 47 out of 133 C-sections that were apparently performed as per the OR manager. Next slide. What we did an audit chart by chart, and two things became quite apparent from that audit. First was that antibiotics were administered by different people during the course of the procedure, and that the documentation of the antibiotic was highly variable in the clinical record. So what you'll see here is that out of the 101 112 charts that we audited, 101 clients had actually received antibiotics. And of those 101 patients that received antibiotics, 94 of them had received antibiotics within 1 hour of incision time, which is what the evidence-based practice guidelines suggest. So what we still didn't know was, of the people that had received antibiotics, how many of them had in fact had infections. So we profiled the people that in fact were identified with infections. And what the profiling showed was that we identified risk factors based on a literature search, and so the profiling pulled out the various risk factors. And of interest, of the 9 clients that had infections in that initial group of data from January to June of 2013, all of them had received antibiotics except for one. What was the common denominator was an elevated BMI, or body mass index, and premature rupture of membranes. Next slide. The first PDSA that we looked at then addressed antibiotic administration. The goal was that it would occur 100% of the time. We reviewed our findings. Next slide. We reviewed our findings with the staff and gathered a number of idea sheets. Next one. And the second PDSA then looked at antibiotic administration that would occur within 1 hour of incision time as per evidence-based guidelines. So as noted previously, antibiotic administration was variable in who provided it or who gave it, and so we created some work standards. And at the completion of our project, what we found, so the completion of the project was a data analysis from July of 2013 through to January of 2014, and what we found was of the 131 charts that we audited, did a chart-by-chart audit, 121 clients had received antibiotics as recommended, which would be a 3% increase from our previous baseline. So we went from 90% to 93%. Next slide. And antibiotics were administered within 1 hour of incision time in 88% of those clients. So we had an initial value of 93%. In our second review, we actually found that it was at 88%. So we had a 5% reduction, which is not what we wanted to see during the course of the project. However, the good news is that, again, we profiled the clients, and out of the one person that had an infection in this second group of data, that person as well had an antibiotic, and again, the common denominator was an elevated body mass index and or premature rupture of membranes. So although the lack of antibiotic is not a common theme in our cesarean site infections, the mistake proofing project is important in removing this as a known variable so that other factors can be addressed. Thank you.
Good morning, everyone. My name is Linda Sims, and I'm here to present our PDSA number 4. Which is to reduce traffic flow in and out of the OR theatre on obstetrics and create a communication pathway to and from the theatre in order to reduce traffic flow. While doing observations for our value stream map, we noticed there's a lot of traffic coming in and out of the main double doors to the operating theatre on obstetrics. Due to poor architectural design, these doors unfortunately open to a main hallway on the ward where there is high movement volume. All kinds of staff, clinicians, patients, and visitors in that hallway. The obstetrics nursing station, which also has high activity, is almost directly across from these double doors. As well, there is no airflow exchange system in the theatre to protect the patient from airborne particles that may enter the theatre when the door is open. Unfortunately, the only other entrance to the theatre is through the nursery, which is not an ideal option either. As identified in literature in reducing SSIs, traffic flow in and out of the theatre is a modifiable intervention, thus this PDSA. After the first observation and count of the number of times that the door opened during surgery while the patient was in the room, it was 46 times. We presented the staff with this information and asked for ideas on how this could be reduced. One of the ideas is pictured here and on the idea sheet, and we carried it out with these stop signs, which we are actually improving as we speak. It was also noted on discussion with staff that communication between the staff and clinicians in and outside the room is very important, but at the moment there is no way for this to occur without actually entering the room. In response to this problem, other ideas were presented from idea sheets, but we felt the best way to facilitate this communication pathway was to go high tech. And so using a wireless device, and this is a picture of it, wireless communication device called Vocera, it could increase communication capability considerably to and from the theater. We tested the Vocera device and we're happy with its range and ability to communicate back and forth with people in and outside the theater. We predict other benefits from this device, such as enabling clinicians like the pediatrician to decrease wait time to better use their time elsewhere. In preparation for the implementation of Vocera, we have developed standard work and a sign-in, sign-out sheet for users of Vocera. The next slide is a summary of the actual count of the main doors opening and closing. The baseline time was 46 times. In January, it reduced to 42 times. And after the raising awareness with staff about why this isn't good, and the stop signs, the total opening and closing reduced to 28 times, which is an improvement of 39%. My last slide shows a trend line of the decreasing times that the doors open during surgery. Thank you, and I should pass it back to Nola.
This is our post-mistake proofing value stream map, and as you can see, our non-value added and value added times percentages have not changed, but we've managed to address some of the starbursts. This is our post-mistake proofing infection graph, and of the 9 out of 112 cases were confirmed post-op infections occurred, and then post-op we had only 1 out of 131 cases, and that was an improvement of 89%. This is our post-mistake target progress report, and as you can see, we've improved in all areas except for the one where our administration timing has not improved. This is our newspaper, and as you can see, we still have some items to address around our work standards for the antibiotic administration and the documentation, as well as around the Vocera. This is our timelines that we're hoping to reach, and by mid-May we're hoping to pass off our project to Angie Emerson and to Lesia from the OR. This is our work summary and our successes and challenges. As you can see, we've had a few, but it's been a lot of work, but we've had a lot of fun working together, and we do feel that up to this point we really have made some changes already. These are our thank yous to our folks. We especially want to thank Angie and her staff, and Leslie and her staff, Colleen from Infection and Control, as well as Linda Luray from my staff. She did all the pulling of our charts for us, which was massive. Thanks.